Hello friends, today we are going to talk about clinical significance of the midbrain. So, the midbrain forms the upper end of the narrow stalk of the brain or brainstem. As it ascends out to the posterior cranial fossa through the relatively small rigid opening in the tentorium cerebelli, it is vulnerable to traumatic injury. It possesses two important cranial nerve nuclei, oculomotor and trochlear, the reflex center, the colliculi, and the red nucleus and substantia nigra, which greatly influence motor function, and the midbrain serves as conduit for many important ascending and descending tracts. As in other part of the brainstem, it is a site for tumor, hemorrhage, or infarcts that will produce a wide range of symptoms and signs. First of all, talking about trauma. Among the mechanisms of injuries to the midbrain, a sudden lateral movement of the head could result in cerebral peduncle impinging against the sharp rigid free edge of the tentorium cerebelli. Sudden movement of the head resulting from trauma cause different regions of the brain to move at different velocities relative to one another. For example, large anatomical unit, the forebrain may move at different velocity from the remainder of the brain, such as the cerebellum. This will result in the midbrain being bent, stretched, twisted, or torn. Involvement of the oculomotor nucleus will produce ipsilateral paralysis of the levator palpebrae superioris and the superior inferior and medial rectus muscle and the inferior oblique muscle. Malfunction of the parasympathetic nucleus of the oculomotor nerve produces dilated pupil that is insensitive to light and does not constrict on accommodation. Involvement of the trochlear nucleus will produce contralateral paralysis of the superior oblique muscle of the eyeball. Thus, involvement of one or both of these nuclei of the corticonuclear fiber that converge on them will cause impairment of ocular movement. Next, cerebral aqueduct blockage. The cavity of midbrain, the cerebral aqueduct, is one of the narrowed parts of the ventricular system. Normally, CSF that has been produced in lateral and third ventricle passes through the channel to enter the fourth ventricle and so escapes through the foramen in its group to enter the subarachnoid space. In congenital hydrocephalus, the cerebral aqueduct may be blocked or replaced by numerous small tubular passages that are insufficient for normal CSF flow. A tumor of the midbrain or pressure on the midbrain from tumor arising outside the midbrain may compress the aqueduct and produce hydrocephalus. With the cerebral aqueduct is when the cerebral aqueduct is blocked, the accumulating CSF within the third and lateral ventricle produce lesion in the brainstem. The presence of the oculomotor and trochlear nerve nuclei together with the important descending corticospinal and corticonuclear tract will provide symptoms and signs that are helpful in accurately localizing a lesion in the brainstem. Vascular lesion. The midbrain houses cranial nerve three nuclei and serves as a conduit for all ascending and descending fiber between the cerebrum and brainstem. Lesion of each will result in the following syndrome. First of all, Weber syndrome. Weber syndrome, which is commonly produced by occlusion of branch of posterior cerebral artery that supplies the midbrain, results in the necrosis of the brain tissue involving the oculomotor nerve and the crus cerebri. Ipsilaterally ophthalmoplegia and contralateral paralysis of the lower part of the face, the tongue, and the arm and leg also result. Eyeball is deviated laterally because of the paralysis of medial rectus muscle. The upper lid droops, ptosis, and the pupil is dilated and fixed to light and accommodation. Benedict syndrome. Benedict syndrome is similar to Weber syndrome, but the necrosis involves the medial lemniscus and the red nucleus, producing contralateral hemianesthesia and involuntary movement of the limbs of the opposite side. Now you can see in this picture, there it shows the pathology of midbrain. First of all, tumor. Tumor of the midbrain blocking the cerebral aqueduct. First of all, you can see here, tumor of the midbrain blocks the cerebral aqueduct. Second, Weber syndrome involving the oculomotor nerve and the crus cerebri following occlusion of the blood supply to the midbrain, that is posterior cerebral artery. You can see here that involves Weber syndrome involves Weber syndrome involves crus cerebri and oculomotor nuclei. You can see this is oculomotor nuclei. It involves oculomotor nuclei and crus cerebri. Then next, Benedict syndrome involving the red nuclei. You can see here. This is red nuclei normal, and it involves in Benedict syndrome the red nuclei is affected. Red nucleus and medial lemniscus also. This is medial lemniscus. Following the occlusion of blood supply of the midbrain. So we have discussed the symptoms of the Weber and Benedict syndrome. What happens in Benedict syndrome? It is similar to Weber syndrome, but necrosis involves medial lemniscus and red nucleus producing contralateral hemianesthesia. Hemianesthesia contralateral and due to medial lemniscus damage or involuntary movement of limb of opposite side. Red nucleus involvement. You can say Weber syndrome produces occlusion of branch of posterior cerebral artery that supply midbrain, resulting in necrosis of brain tissue involving the oculomotor nerve and the crus cerebri. Due to pain oculomotor nerve paralysis, there will be ipsilateral ophthalmoplegia and contralateral paralysis of lower part of the face, tongue and arm and leg also results. Eyeball is deviated laterally and upper eyelids will dilated, fixed eyelid, that and accommodation. So this is all about pathology of midbrain. Thank you.